Good morning. It's my pleasure to be here with you today. First of all, I'd like to express my deep gratitude to Professor Dr. Hisham for inviting me to this event. Today, we are going to discuss HCC update in diagnosis. We are going to discuss what is LIRADS version 2018, how to assess treatment response by LIRADS version 2018, and recent imaging modalities in assessing HCC. First, LIRADS system, it is known as Liver Imaging Reporting and Data System. It is a reporting system created by ACR for standardized interpretation for liver imaging in patients with a risk at HCC. It was initially developed on 2011 and then updated on 2013, 2014, 2017, and the last update was 2018. Its aim was to reduce the variability in the interpretation of imaging findings between different radiologists and to improve the communication through standardized reporting and facilitate therapeutic decision making. And this allows easy interpretation with the clinician, what we mean in our reports and how to plan for therapeutic management of this patient. Let's see how classic HCC appear on imaging. This is an MRI. This is a T2 weighted image. We can see over here that there is a well-defined lesion at the left hepatic loop over here. It appeared to be slightly hyper-intense on the T2 weighted image. It is more appreciated here on the fat suppressed technique, being of higher signal compared to the background hepatic parenchyma. And this is the in and out of phase image. We can see that the lesion appear to be iso-intense to the hepatic parenchyma. Sometimes HCC can have fat content that appear to be of dropped signal here on the out of phase image. And this is the reversed diffusion weighted image and ADC map showing high cellularity of the lesion with the restricted diffusion, which was confirmed on the ADC map. On the dynamic study, this is the classic appearance of HCC, which appear to be hyper-enhancing on the early arterial phase with gradual washout and delayed capsular enhancement. This is the classic appearance of HCC, and unfortunately, today, we don't encounter such a classic appearance in our routine imaging because of the repeated imaging and multiple interventions the patient perform for their focal lesions. So how to minimize the interpretation fallacies between different radiologists? This is the LIRADS scoring. It is divided into multiple scores from 1 to 5, depending on the confidence in diagnosing HCC. Being LIRADS 1 means that this is a definitely benign lesion, and we are not suspicious for being having an HCC in this patient. And LIRADS 5 lesion, which are definitely diagnosed as HCC. Why LIRADS 5 is a definitely HCC diagnosis? Because HCC may be the only pathological entity that can be only diagnosed by imaging without the need of further histopathological verification. So LIRADS 5 is just confined to the lesions that show classic appearance of HCC, and they are definite to be an HCC, as we mentioned earlier. But if we have a suspicion that this is a malignant lesion, but it could be HCC or it could be another different malignant lesion, then we, or it could be just a high-grade dysplastic nodule, then we can call this lesion as LIRADS 4 lesion, and this is a probable HCC, but not sure to have an HCC. And LIRADS 2 and 3 ranges from probably benign to intermediate probability of malignancy. But if we have a malignant looking focal lesion in a patient with a known cirrhotic liver, then we can call this lesion as LIRADS M. LIRADS M can have the lesion to be an HCC, or it can be another different malignant focal lesion, for example, cholangiocarcinoma or hepatic metastasis from other primary. But unfortunately, imaging alone can't discriminate between these images, these entities, and we can call these lesions as LIRADS M. Lyrase scoring to be fulfilled, the patient should have liver cirrhosis and not with the underlying veno-occlusive disease. So we can't apply the Lyrase scoring on patients with Budd-Chiari nodules because sometimes the nodules show early enhancement and wash out simulating HCC, and they are just regenerative nodules associated with the Budd-Chiari disease. So these are confined only to patients with known liver cirrhosis and the cirrhosis not due to underlying veno-occlusive disease. Another new entity that was described by this Lyrase scoring is that LRTIV, which means that we have a tumor in a vein. It means that we have a malignant looking focal lesion that we can call it definitely an HCC, and it's not only confined to the hepatic parenchyma, but it infiltrates the adjacent vein, either the IVC, the hepatic veins, or the portal vein, or any of its branches. And this is known as a tumor in vein. How can we score these lesions, especially Lyrase 3 to Lyrase 5? This is a simple way, and it can be applied either on CT or MR imaging, depending on the pattern of enhancement, the size of the lesion, and some specific criteria, which are known as major features, including washout, enhancing capsule, and the threshold growth. So we can discriminate between the lesions depending on these multiple parameters according to this table, and fulfill the criteria of each focal lesion and put it here in its corresponding category. So there are minor lesions that are located here in the Lyrase 5 because these lesions don't need any further histopathological confirmation, and management should be promptly performed for these patients. However, other lesions like Lyrase 4 or Lyrase 3 lesions, these lesions could be either biopsied or could be followed up to confirm their nature. Either they are just benign lesions or they are progressed into a true HCC. Then a new criteria was reported in the Lyrase scoring system version 2018, which is the treatment response assessment. Because the application of the other assessment of solid tumor response for HCC doesn't apply in patients after locoregional treatment. Either the RESIST or the EASL, they have some fallacies in diagnosing the patient response. So this is a very easy way to assess the treatment response by in every routine day practice, and it depends on the enhancement criteria present after the locoregional treatment for HCC. If we don't have any appreciable enhancement, this is known as LRTR non-viable. And if we have an enhancement, but we are confused if this enhancement is just as a post-treatment change or it is a small residual tumor, we can call this as an equivocal lesion, and short interval follow-up is advised. But if we have suspicious for residual viable tumor, it is called as LRTR viable. And these include either nodular or mass enhancement, irregular peripheral enhancement, early washout, early enhancement, and early washout, as the enhancement pattern noted on the pre-treatment imaging. How to assess the residual viable tumor? Initially, there were multiple methods to assess the residual tumor. We are just assessing the maximum length of the residual enhancing component, and don't measure the lesion as a whole, because the central part is the lesion that was targeted for the therapy and it was treated. But the residual tumor are usually located at the periphery of the lesion. So we select the largest diameter that we can see enhancement within this largest diameter and measure the diameter like this. If the lesion is circumferentially viable, we measure the largest viable area located over here. But if we have just a peripheral nodular enhancement, we just pick up the largest nodule and measure the largest dimension for this large nodule. So how can we assess HCC by CT or MRI? This is controversial, as the Professor Dr. Amr mentioned earlier. There is no solid guarantee which is better, CT or MRI, but let me share with you some of our cases. These are not cirrhotic patients, just to show you the similarity between CT and MRI. These patients was presented to our department with abdominal pain and ascites, and ultrasound detected the small focal lesion. Here, this is the CT for the patient, and this is the MRI performed 2 days after the CT. Unfortunately, on the CT images, we can't interpret all these focal lesions. The time interval between two imaging were just 2 or 3 days at most. Another entity that CT is a superior in vascular assessment, like this patient, we can see nicely the portal vein thrombosis as well as the hepatic parenchymal affection in a post-traumatic patient. But here in MRI, even without the use of the contrast injection, we can see this nice tumor, this nice portal vein thrombosis, even without contrast injection. So MRI is not just superior in the assessing the number and the multiplicity of the focal lesions, but also it is helpful in patients with kidney affection, especially in the cirrhotic patients, and we can perform a non-contrast study for assessing their vascular structures and if there are any associated thrombosis of these vessels. The gold standard role of MRI is post-treatment assessment, especially if the patient have performed chemoembolization, because the dense lipidol condensation can mask the underlying residual viable tumor. Let's see this patient with the previous chemoembolization. We can see that there is dense chemoembolization located at the periphery of the lesion. However, there are non-lipidol condensation noted at the center of the lesion. And this is controversial if this is a complete treated lesion or there is still underlying small residual viable tumor. This is the early arterial phase and this is the delayed image. Can you tell me if this is a well-treated lesion or this is showing residual viable tumor? Actually, it is very difficult to call from this CT. And the patient was actually reported as a well-treated lesion with no appreciable enhancement, because it is very difficult to appreciate enhancement in such an artifact with the lipidol condensation. But the patient has rising alpha-fetoprotein after the chemoembolization, and there were suspicion for residual viable tumor, so he was referred for MRI. This was the T2 weighted image showing heterogeneous appearance of the lesion, and we can't rely on the T2 weighted image to discriminate between viable and non-viable tumor after local regional treatment. So we need further dynamic study. This is the arterial phase image. We can see that there is a non-enhancing portion located at the periphery of the posterior part of the lesion. However, there is an iso-enhancing lesion located at the anterior part of the lesion. Is this enhancement is a true enhancement, or is this just from the hemorrhage and post-therapeutic change? So we performed what is known as the subtracted image to conclude the exact presence of enhancement, and it was proved to be enhancing lesion. And this enhancement in the subtraction denotes that this is a true residual viable tumor. And if we are just comparing it with the CT, we can notice that this enhancement partly corresponds to the area of non-lipidol condensation. And on the delayed image, we can see that this part in particular shows the washout compared to the early arterial phase. And this is the superiority of the MRI to assess post-treatment changes for the assessing residual tumors. As regards the radiofrequency after ablation, MRI is very easy, and also CT plays a very good role in assessing radiofrequency ablated lesion. This is the ablated lesion appear to be dark on the T2 weighted image due to the coagulative necrosis with no restricted diffusion, and on the T1 weighted image, this is the arterial study. This is hyper intense lesion, and this hyperintensity is likely due to coagulative necrosis. So when we refer to the subtracted image to exclude that this is just coagulative necrosis or residual tumor, there were no related enhancement, and this indicates that we are dealing with a well-treated lesion. However, unfortunately, there is another smaller lesion that was interpreted over here, and it has an intermediate signal on the T2 weighted image with restricted diffusion. Then the lesion is showing enhancement, and it was a true enhancement that was detected on the subtracted image, followed by washout. So we can't only assess the treated lesion, but we are searching for other newly seen focal lesions and assess if they are true HCC or just dysplastic nodules. And this is the power of MRI. We can also assess another different pathology located within the liver, this smaller lesion, which is of hyperintensity on the T2 weighted image, and it shows no appreciable enhancement, and it is just a simple hepatic cyst. So MRI can categorize multiple lesions with the characterization of every single lesion separately with more accuracy than CT. As regard the post-test, as we mentioned earlier, MRI is very important because it allows the discrimination between residual tumor and post-treatment change. As we can see over here that there is a heterogeneous enhancement noted at the periphery of the lesion with non-enhancement central part. However, there is a wedge-shaped area of homogeneous enhancement located posteriorly, and this wedge-shaped area of enhancement is just due to adjacent peripheral inflammation and perfusional change as a post-therapy change, and it was persistent till the delayed image. However, the residual viable tumor show early enhancement that was proved on the subtracted image and followed by washout on the delayed image. And this, how can we discriminate between post-treatment enhancement and the actual residual tumor? Another rule of imaging is to assess complications after interventions, which could include injury of blood vessels with formation of arteriovenous shunting, injury of the biliary ducts, abscess formation, although not common, but it can encountered especially after TACE. And also the needle tracking seeding, which can occur sometimes in radiofrequency ablation, and nowadays we are not visualizing this rare complication. This is an example of a treated focal lesion which appeared to be well treated, yet there were injury for the biliary tree adjacent with mild intrahepatic biliary dilatation. Another well treated lesion with no complication over here with the overlying capsular retraction due to the well treated pattern, and the lesion was not enhancing at all. This is an example of hepatic abscess after TACE formed at the site of the treated lesion, and it was confirmed by the diffusion weighted image as a true restricted diffusion with air inside and no appreciable enhancement. The lesion was well treated, but unfortunately there were abscess performed at the site of the lesion, and it was tapered, and it was proved to be having pus inside, and the patient improves after the aspiration of this abscess. Some of our new techniques and power in the MRI is what is called the IVIM, which is a new imaging modality depending on the diffusion weighted image, and it is known as intravoxel incoherent motion. This technique depends on assessing the vascularity and the cellularity of the lesions without the need to have a contrast injection. This is an example of a focal lesion located over here, and the lesion was having the classic appearance for being an HCC. This was the IVIM, and it shows that the lesion is having a high vascularity depending on the FP value, which is a reflection of the microcirculation of this lesion, and also it has a moderate cellularity, which was a reflection for the D value proved by the IVIM. And after treating this lesion by TACE, this is the arterial phase subtracted image showing a complete treatment of this lesion with no appreciable enhancement noted. And the IVIM data correspond to the dynamic study with the significant reduction of the FP value located over here compared to the initial data. And this indicates that the lesion is well treated with no appreciable residual viable tumor inside. Also, the cellularity of the lesion, which is measured by the D value located over here, is also showing increase in its number, which means that there is less cellularity noted in this lesion, and this is a well-treated lesion, and it is a potential tool to be used in patients, especially those having renal disease. As regards PET imaging, which is a new era in the diagnostic tools available nowadays, PET imaging unfortunately have some limitations regarding HCC, because as we can see in this patient, this is a heterogeneously enhancing focal lesion that shows washout, and it is proved to be an HCC. And on the PET image, this lesion appear to be avid on the PET image, and this is the fused PET-CT image which was avid. Unfortunately, if the lesion appear to be avid on the PET image, this means that this HCC is undifferentiated or poorly differentiated HCC, and this indicates the higher aggressiveness of this focal lesion. But the well-differentiated HCC, which appear to be hyper-enhancing with washout on the conventional image, appear to be negative on the PET imaging, and this indicates that this is a well-differentiated HCC. So if we perform HCC, sometimes we can miss some of the HCC, especially if they are well differentiated, but it can give us an idea about the histopathological nature of this focal lesion, whether it is of the low grade or the high grade HCC, and it could help in the prognostic assessment of this HCC. PET-CT is also very helpful in assessing post-treatment changes, especially if we are performing the loco-regional treatment as a bridge for hepatic transplant, because we need the proper staging not only for the hepatic parenchyma, because we are going to remove all this hepatic parenchyma, but also for the distant metastatic load in these patients. This is an example of one of our cases showing that this show avid uptake in the site of the previously treated focal lesion. This is the lipidol condensation, and this is the avid uptake at the site of the lipidol condensation. And not only that, which indicates that there is a residual hepatic viable tumor, but unfortunately there is another distant left supraclav lymph node which denotes distant metastasis, and this can hinder the procedure for liver transplant. Another example of the PET-CT, it can differentiate between tumoral thrombosis and non-tumoral thrombosis, as we can see here that this is a tumor protruding into the right portal vein branch, and it was avid on the PET-CT, and this indicates that this is tumoral thrombosis and not just a non-tumoral thrombus. If you need the further reading, these are our publication about the MRI in assessing hepatocellular carcinoma after loco-regional treatment, and also the value of PET-CT as a bridge for patients who will undergo liver transplant. Thank you.
شكرا جزيلا دكتورة رشا. يعني كالعادة الأسلوب البسيط السهل، المحاضرة طبعا من كل الجوانب. شكرا جزيلا لحضرتك. المحاضرة